Research is the cornerstone of innovation in clinical practice, driving improvements in patient outcomes and shaping the future of medicine. Welcome to the Global Rhinology Network Topical Research Symposium. I'm Ashok Rokade from Winchester, UK, and it is my privilege to welcome you as a host. Joining me as co-hosts are Louise Melia from Bath, UK, and Professor Thibault Van Zele from Ghent, Belgium. This symposium showcases fascinating topics across 4 key modules: General Rhinology, COVID session, and Research in Chronic Rhinosinusitis. A special highlight is the PhD session featuring research conducted by enthusiastic young rhinologists who represent the future of our field. This symposium brings together leading global minds in rhinology who will highlight latest developments with a focus on translating research into impactful patient care. The Global Rhinology Network is dedicated to advancing knowledge innovation. Thank you for being part of this exciting journey. Thanks to Medtronic and Karl Storz for their generous support in making this symposium possible. Welcome to GRN Topical Research Symposium.
It's my great pleasure to introduce Dr. Martin Desroseirs. He is a well-known clinical professor from Université de Montréal and also a sinus surgeon at the University Hospital of Montreal. He has done a lot of work on microbiomes and is now a researcher at the CRH-CHUM, where he is leading the Living Sinus Laboratory, and he has a special interest in epithelial dysfunction in CRS and also viral pathogens in CRS. So I'm looking forward to his talk on inflammation, not all type 2. So Martin, please go ahead.
Thank you very much. If I could just share my screen for a moment. There we go. That will be terrific. And I would just like to thank the organizers for giving me the opportunity to come and talk about this. I've enjoyed listening to the other speakers this morning, and it's this exchange and cross-fertilization of ideas, which is so beautiful and which makes the scientific world so agreeable to live in. And I'd like to talk to you about what we're doing today. And we're going to talk about non-type 2 inflammation. So my disclosures are that I have an amount of clinical research funding in type 2 disease. However, the type 1 disease is truly all internal funds that we've generated over time. So as a sinus surgeon, and I'd emphasize this in this day and age, that I truly do remain a sinus doctor and a sinus surgeon and do surgery and believe in it. The objectives to managing chronic sinusitis with endoscopic sinus surgery are pretty clear. We'd like to get a well-healed cavity without any edema, with patent ostia and no polyps as such. This would be an optimal outcome. It's difficult to get this, and we get this in not every case. So because I would like everything to be perfect, we have run for the past 15 years a genetics of chronic rhinosinusitis, or what I call the living laboratory, where we try to work with human subjects to try and identify different causes. This shows the earliest branch of the effort that you've all been familiar with, where we collected DNA to identify genetic variations between individuals with chronic sinusitis and without. And we see here what you call a Manhattan plot, where you see all the genetic differences, but you can see that some of these stick out like a sore thumb. They're quite different, and they're very significant. And what's interesting is these tend to accumulate or collectively gather or be identified within areas of the extracellular matrix or of the connection of the epithelium to the extracellular matrix, identifying the epithelium as a portion of this. And this led us to reconsider what we had been taught and how we considered the epithelium about a decade ago as not a sterile barrier, but rather an interface, which detects and coordinates aggressive responses. And since then, this has been borne out by all the interest that has since emerged in the epithelial barrier in CRS with NP, notably within type 2, but also within other disorders where the dysfunction in the barrier is related to a tissue remodeling and chronicity of the disease as such. So we've been working with an epithelial biologist, Emmanuel Brocchiero, in our center to explore epithelial physiology using what Valerie Hawks, congratulations, Valerie, that was very nice, sinus organoids. So air-liquid interfaces can be considered as representing a mini version of the sinus as such, and that this lends itself to experimental manipulation. As Valerie shown, we can add pathogens, we can add also different cell types or supernatants, and we can also perform functional assessment using repair from wounding. I'll go into that. And then all the responses to these can be profiled in a hypothesis-free fashion, covering the entirety of the expressome using transcriptomics. Valerie did such a good job, much better than I will, of describing polyculture. I'm just describing wounding. What we do is we perform a scratch in the epithelium and watch it close. And it's the speed and the organization of the migration that we can follow. And with this, then transcriptomics, of course, is gene expression with chips that we then work by taking the individual results using a form of artificial intelligence and grouping them into pathways, which let you understand disease. And I'll show you a lot of examples of this. So the first fact we came in that was important was with Fabiana Valera from Brazil, is that epithelial repair in chronic sinusitis patients is slower than in controls. And that this is, in a note to what Sarah just presented, exacerbated by Staphylococcus aureus, suggesting what a professional pathogen Staphylococcus aureus is in terms of its pathogenesis. It's actually preventing the epithelium from healing. Lastly, this is a decade-old slide that we're only beginning to appreciate, is that we are able to profile these epithelial cell cultures in vitro, away from all the toxic exposures, smoking, white blood cells, rinses inside the nose, bacteria. We grow them in a sterile container and we see their baseline characteristics. And what's interesting is if we compare a population of primary epithelial cells raised from humans with controls, no disease, and a mix of patients with chronic sinusitis and nasal polyposis, we see two separate types of inflammatory endotypes in the diseased population. One that's a high inflamed one with a high expression of type 1 and a dramatic decrease in epithelial markers, and a lower inflammation CRS, which we call CRS2, which has intermediate type 1 inflammation and a persistence of some epithelial activity. What's interesting is that these biopsies that are in vitro phenomena correspond to biopsies that come out of the patient directly. And if we compare, for example, the clinical phenotype with the epithelial endotype, we see that this high and low inflammation CRS1, CRS2 is accompanied by a higher presence of CCL2 on biopsies. Whereas if we just use the CRS with NP, CRS without NP, we see that it's a mix. We can't predict for the inflammation. There's too much overlap. Same thing goes for eosinophilia. While nasal polyps seem rich in eosinophils, it's suggested by the epithelial endotype that eosinophilia is not driven as such by the epithelial endotype as such. It appears the same. So there's some very interesting points coming out of this, is that we are very much interested in type 2 inflammation, but we are also pursuing bacterial and viral origins towards disease where T1 inflammation must be involved. And this suggests that we need to pay more attention to type 1 inflammation, and I apologize if I'm repeating what other speakers have said this morning. The second point is, this is not a yin-yang either-or phenomenon. It is that if we look at helminth infection in this beautiful review from what seems centuries ago, but it's actually a decade ago, it's type 1 and type 2 immunity will combine forces to fight helminths. So you will get an effect from the type 1 and the type 2 at the epithelium. So this should not be unexpected. Now, we have some good ideas for type 2, but what does type 1 do? Well, one of the first things we did was simply take a type 1 cytokine and add it to epithelial cultures in an air-liquid interface. And what was interesting is we saw that adding TNF brings about a stimulation of type 1 genes, but that immediately we get a down regulation in markers of epithelial differentiation and proliferation. And we also get an impairment of a functional wound repair assay. And when we look at our transcriptomics analyzing this in terms of pathway analysis, we see that these are in G1 paralysis, that the cells are paralyzed, incapable of moving forward in their progression of differentiation, leading to a dysfunctional repair process because the epithelial cells cannot behave as suspected. So we've taken a lot of this information to try to add it to surgery and understand how does surgery work, and getting back to the original problem, how could we make surgery work better? Well, we've looked at this by modeling this. So with the help of Anastasios Maniakas and Axel Renteria, we've performed clinical trial taking 116 consecutive patients that underwent surgery for what we'd call high-risk disease, and that these patients were all operated by a single surgeon, myself, put on budesonide irrigations, and then maintained. And what we saw that if we use the image in the upper right-hand corner that I showed earlier as our desired outcome, 50% of patients do achieve this so-called perfect outcome, which is great, but 50% don't. So we have structured this trial so that the group that did not attain a perfect outcome were then treated with either azithromycin or a blinded placebo for azithromycin for 4 months, where then they were measured. And we looked at the responses here. I won't go deep into the transcriptomics because it doesn't fascinate everyone. But what we see is for these patients that do not respond to FES is they have an upregulation of type 1 inflammation, linking failure of surgery and type 1 inflammation. And again, in parallel with the in vitro findings, our in vivo findings of the complicated model that is real human disease also suggests epithelial barrier dysfunction. So this shows that type 1 is involved in failures. I'm sorry for that. You get to see my whole computer. If we look at the successful cases, we see that recovery from surgical injury involves epithelial regeneration and renewal and a reduction of type 1, type 2 inflammation. So we know what desirable would be. But let's stick with the undesirables for the moment. So if we have patients that are failing, that have high type 1 inflammation and epithelial dysfunction and a persistence of Staph aureus, maybe we should target epithelial dysfunction and type 1 disease. Now, in this age of type 2 monoclonal antibodies, this might seem a challenge. And I would tell you that type 1 biologics have not been assessed in chronic sinusitis. We've used azithromycin as a light version of a biologic. It's not a biologic, it's a small molecule, of course, but azithromycin has described anti-inflammatory mechanisms that make it useful not just as an antibacterial, but also as an anti-inflammatory medication for type 1 disease. And this has been used in chronic sinusitis, cystic fibrosis, and bronchiectasis. We've modeled this in our air-liquid interface, and we've shown that adding azithromycin reduces IL-6, a marker of type 1 disease. And we've also shown with the help of Fabiana Cardoso that we improve repair that's induced following addition of Staphylococcus aureus to our cultures, so that azithromycin improves repair and differentiation. And when we profile this using transcriptomics to look under the hood and see what's going on, again, it suggests that we're getting a modulation of type 1 inflammation and a restoration of epithelial barrier function. So azithromycin strikes as a reasonable treatment for refractory chronic sinusitis, given the type 1 component. And we performed this in this population that had failed chronic sinusitis. So this reminds the trail following a failure of surgery, with a very robust definition of failure of surgery. We performed epithelial brushings for gene expression profiling before and after treatment. here you see the heat map, and mostly what you see is that following azithromycin treatment in responders, type 1 responses reduce, which is what we expect. Surprisingly, type 2 markers do reappear, and postin, markers of mast cells, and type 2 associated cysteine antiproteases are higher than pre-treatment, despite the success. And the mechanism of response involves, as seen from in vitro data or as suggested, is that we get progression of the cell cycle, restoration of epithelial function, and reduction of type 1 immunity. So that suggests that azithromycin can play a role in correcting post-ESS dysfunction, and it's quite a role. So I'd leave you with, looks like I need to convert this crowd, the idea that epithelium is important in chronic sinusitis. We've shown this in vitro, and more importantly, we've shown this in vivo. Type 1 doesn't mean that we can ignore type 2. Probably we need to consider managing both of these. And in the way that we characterize a type 2 response, or we try to using biomarkers, we may also want to try and characterize type 1 immune status to see if we need to intervene. And ultimately, I argue for rehabilitation, but rehabilitation of the epithelium in order to restore proper healing. You'd want an open wound to close and be clean, leaving no scar. We'd like the same thing for our sinusitis. We are, as Sarah mentioned at the beginning, but I think we're beginning to see a path forward with some support for this. And I'd just like to say that I don't think that solving CRS is impossible. I think it's coming. And with a team like this, I don't think that this is going to be an impossible challenge. Thank you very much for your patience.
Thank you, Martin, for this very inspiring presentation. Are there any questions from the people who are attending, or
Yeah, I have a small question. Hi, Martin.
Sarah.
Nice to see you. Just with your clinical study using azithromycin, how much of an effect do you think this is due to the antibiotic effect of azithromycin? Do you have any indication for this, or can you control for this, or yeah?
It depends. We can't control for it, unfortunately. There are compounds under development by pharma to attempt to harness the anti-inflammatory properties of the macrolide while decoupling them from the antibacterial properties to avoid problems with resistance. You could say that azithromycin is not a good staphylococcal antibiotic. You could also say that azithromycin doesn't have the same concentration in every compartment. And for example, in secretions, it is increased to a considerable degree, about 8-fold. And within macrophages, it's concentrated about 50-fold. So were staphylococci to be having residence within the macrophage, well, then the level of azithromycin that could accumulate within the macrophage could possibly be bacteriostatic or bactericidal. However, I tend to think it's more a matter of ecology, that you change the environment by making, you're closing the wound, you're removing all sorts of fibrin for the bacteria to attach to, and the staphylococcus no longer sees an opportunity to exploit and simply goes away. Much like what we're seeing with Trikafta and cystic fibrosis. The Pseudomonas just falls off the mucosa.
Yeah, true.
Noam, you look like you have a question. You turned your microphone on. Good to see you, though.
I turned my camera on, but I didn't turn my microphone on. No, I was just responding to a resident text. Sorry, no, I'm good. You still baffle me. I'm still trying to digest everything that you threw at us. It will take me a while. It's like a Woody Allen movie with you. It regurgitates on me after a couple of days.
Martin,
I left out a lot of stuff, Noam. And Sarah, if it's any consolation to you, we're very much interested in the viruses now. Not so much in terms of the bacteriophages, but the viral population. And the concept that's coming out of the gut is that the bacteriophages modulate the microbiome and they control the destiny of the microbiome. So I think the bacteriophages look like a great therapeutic opportunity and something that's worth exploring.
I agree, Martin. I'm very much for bacteriophages, and they are understudied. So that's something that we should look at in future.
Martin, if I may, there is a question on behalf of our clinician trainees, that when you refer to azithromycin, are you referring to the macrolide family in general or specific to azithromycin? So what about clarithromycin, erythromycin?
I know that a lot of people will use different types of medication for macrolides. So this is presumed to be a class effect of macrolides as such, with josomycin, roxithromycin, clarithromycin, azithromycin. Why I use azithromycin clinically is this is a recipe that's been used for 30 years in my part of the world without any real complications. And when you look at the major objection, which is the development of arrhythmias, erythromycin, clarithromycin have 5 times the rare incidence of arrhythmia that azithromycin does. So azithromycin is easier for that. Because of the long half-life for azithromycin, it can be given more infrequently. We give 250 milligrams 3 times a week. And often patients with clarithromycin will complain of a metallic taste within their mouth, and this can hurt compliance. You don't see this so much with azithromycin. So that plays for that, and we've focused on that agent. I don't know if you can extend that directly to the others.
So can you explain what is your clinical protocol for azithromycin prescription? How
Absolutely. So for using azithromycin is anybody who shows a response which is suboptimal following surgery. And this can be up till 2 years following surgery. I will give them a trial run of azithromycin. I will administer azithromycin 250 milligrams 3 times a week if they don't have contraindications. Most contraindications include a existence of a pre-existing cardiac arrhythmia, and I have concerns regarding using them with beta blockers in terms of the QT interval, so I do not administer them with propranolol or something similar. Otherwise, the patient goes for a 4-month treatment with azithromycin. I encourage them to realize that it's not going to help for the first month. We are rebuilding the epithelium. It is tantamount to gardening. It's like watching grass grow. So to not expect an effect before 1 month. I'll see them at 2 months. At 2 months of this 4-month journey, I hope to see progress in the direction I am expecting. And if I see a change and improvement, I will continue. Because often at 4 months, what you get is perfection. It reveals the disease underneath and doesn't give you half a result with like a whole bunch of edema and polyps left. No, you see everything and it's perfect. It's what you dream of. So that based on the experience, this is what we use as a target. Patients often, about 2/3 of patients get durable responses to azithromycin where they remain well for prolonged periods. Something just snaps back into place, the ecology is lined up, and the sinuses maintain themselves. Other patients will show that despite an initial response, they recur. They then go on azithromycin for a more prolonged period, which is usually coverage during the 8 winter months in Canada and a drug holiday over the summer. And this seems to work relatively successfully. And to answer rapidly, can you use azithromycin with dupilumab or another biologic? Absolutely. And when you hear the lung doctors telling you, I use 2 biologics, be proud. Tell them, I'm controlling both ends of the immune system as well, but 2 different types, not 2 drugs for type 2. So I think that actually because of our angle and our capacity to manipulate the system, we're actually understanding better resolution of the disease and moving forward in that direction.
Thank you.